Very big school. So shall we start, sir?
Yes.
Go ahead.
Okay, sir. Good evening, and my name is Vel Arvind. I am the today moderator, and along with Raj, this program is taking more and more credibility among many people in our country, even across the globe. And today is a 34th meeting, and this is combined with Inform Avatar. As we put it in the post. There's a reason we cited was that time Nadiya meeting was there. We postponed, and it could be the one talk is. Rightly coincides with our transplant. So Balasar is none other than Balasar is going to present on that topic. So we decided to combine, and this is the first combined meeting ever started in between when two programs running parallel. Today is the first meeting we combine. So this is 34th meeting. I invite you all with open arms, because this gives us a lot of really confidence in our encouragement to go further in learning process. So today we have two very important speakers as well as a panelist. Dr. Balasar is going to present the first case, and followed by Dr. Ilangovan. Dr. Balasubramaniam Jayaraj, sir, who is affectionately referred to as Dr. J. Bala in our region, in our place, southern part of Tamil Nadu, and even entire India. Is widely recognized in our country for his numerous contributions in the field of nephrology. He continues to demonstrate pioneering ideas and unwavering dedication even after 4 decades of practice, showcasing not only creativity but also innovation. One of his recent ideas involved the contrast USG and its application in renal transplant. Sir, we hold great admiration for you, particularly for your generosity in providing opportunities to the young interventionist. Today, you are leading us into a new chapter in our learning. We deeply appreciate your idea of integrating inform and peculiar cases in renal transplant, in which you are the one of the key speaker. So we are truly grateful for this opportunity. Welcome you, sir.
Thank you.
And next, Dr. Ilangovan is the speaker. Dr. Ilangovan Veerapan from Coimbatore. He had a very impressive beginning in his medical school and is proud to have achieved many achievements during his postgraduate and a decade-long practice in this region. So he is a nephrologist of a truly different category, in my opinion, because of his highly analytical skills. His concepts are very crystal clear. Today, he has volunteered to present a case in which I think he might propose a new concept which may indicate a paradigm shift of our focus. So I had a chat with him in the morning. I think I didn't reveal much because even I didn't ask much about the case details. He said something is going to be different today. So I think his case will bring forth certain new ideas that he has conceptualized, such as I think dissolution by particle detachment. Is it correct?
Dissolution. Yeah, you're right, sir.
Dissolution by particle detachment. I think I got your point little in the morning. So let me not steal the thunder, your thunder, because you're going to reveal a lot of things. And so we have a good, very admirable panelist. One, Dr. V. Shivkumar, sir. Tirupati has not only Lord Venkateshwara, but also a humble human being, in my opinion. Sir has had an illustrious career as a great academician and an exemplary teacher. He is currently the HOD of Sri Venkateshwara Institute of Medical Science. Sir is a proud, I think he's a proud student-centric teacher. And every time he is surrounded by many students for, kind of advice, and he's such a good appreciated mentorship in his life. And he's a very pragmatic administrator, it seems. So, sir, once again, we are delighted to having you here today, because I think this is the second time we are inviting you. And I think your contribution, your presence make a lot of change. I mean, a difference in our in this, adding a lot of weightage to this program, sir. And
thank you.
So next, Dr. Suhas Bhavikar is a highly experienced nephrologist based in Aurangabad, Multi Super Specialty Hospital. I think with over 3 decades of expertise in the general nephrology, interventional nephrology, and renal transplant. And sir is, I think, sir is a very his precise insights. I could sense from his post and comments in the both Inform and peculiar case renal transplant group. I think his precise insights and articulate contribution both Inform and PCRT. I think it reflects his unparalleled wisdom accumulated over the years. I think 3 decades of experience is putting it in a very nutshell, very, very clear, crisp manner. So despite showing no signs of slowing down, I think his daughter is taking over, but I think he doesn't show signs of any slowing down. And your legacy is admirably carried forward by your daughter, Sir Purva. I think she is a true reflection of your exceptional skills. Your presence is deeply appreciated here, sir.
Thank you. Thank you.
So I think let's not waste time on this introduction, and we'll go straight into the topic. I invite Dr. Balasurian, sir. Bala, sir.
Yes, I'm here.
Go ahead, sir.
Yeah. Good evening, friends. I think I should thank Vel Rajan and the two platforms for having given me this opportunity. And let me start. Why I am always fascinated by these imaging studies, and I think that will give a better perspective. See, I like Vel and all. We started our practice in centers away from cities, and we had to do many things ourselves. And one thing I was struck was doing Dopplers, because I started doing transplants in 1996, but there was nobody to do ultrasound Doppler of grafts. So, I mean, you can't imagine continuing a transplant program without somebody to do ultrasound Doppler. So then I took it on myself and it started learning. So that is how I entered into ultrasound, and all these new modalities gave me more and more kick, and I started trying to see things which could help me better diagnose without more invasive stuff. So initially I was dabbling with Dopplers, and you know how Arvind and you have indicated some of the subtle findings where Doppler can be very helpful. And I extended it to acute kidney injury, taking a cue from transplant grafts about the resistive index and so on. So I even tried to differentiate between glomerular diseases and interstitial diseases in AKI, so that if and I presented it long back in Rimini, I think, in a ERA EDTA, and it was also given a platform in one of the WCN satellite meets. So then I was fascinated by elastography. Again, elastography was only used for organs like breast and prostate and superficial organs. But transplant graft being superficial, I thought, why not try this? And I had a mission with capabilities of elastography. And again, there are two types of elastography, and one was the strain elastography, which is more or less obsolete now. With that, I could pick up, try to differentiate between calcineurin toxicity and rejection, with the premise that calcineurin toxicity is vasoconstrictive, so the graft would become softer, whereas rejection would be full of interstitial infiltration and harder. So I was trying to differentiate, and I had good success with the older strain type of elastography, but later it was superseded by the newer technique where you don't need to press your probe. The probe itself was giving pulses of ultrasound waves, which could give differential pressures. But somehow I could not reduplicate the results in the newer technique. So many people didn't, I think, go on to do that. Then I came across this contrast ultrasound, and again, this has been around for quite some time. Like Dr. Varikar said, somebody doing there, but I'm sure it will be for generally differentiating between benign and tumors and malignant ones and cyst versus solid ones and things like that. But I thought, and we know that transplant is an area where it is the most fascinating thing, and the one which attracts nephrologists, and nothing like seeing a nicely functioning graft. And I think now we, as international nephrologists, more of us around, we have better things to give us new thrills, like creating a fistula and getting a thrill there, and doing a cath lab intervention or AV fistulas and getting a closed fistula opening. But nevertheless, transplant and a functioning graft is a glorious thing. But At the same time, graft dysfunction can be very frustrating, and evaluating and fixing the cause of the graft dysfunction even today continues to be a vexing problem. Only renal biopsy continues to be the gold standard. Various imaging studies like B-mode, Doppler, all this, and even newer things like elastography, MR spectroscopy, these are all have been tried, but none of them stood the test of time. But we are ever looking for some modality which is non-invasive, non-nephrotoxic, repeatable, reproducible method which can contribute to early diagnosis. And that is why I started looking at this contrast ultrasound and its role in evaluating renal allografts. And the vascular perfusion can be better assessed by um, this contrast ultrasound because the micro bubbles are used which can reach the capillaries, and more than the Doppler and the other methods we have, this can give us the ultrastructural vascular perfusion that has been shown in other organs. And we know that 50% of all rejection episodes are subclinical and they occur without changes in standard parameters such as creatinine, etc. And vasculopathy, even in both immunological and other vascular events, can happen in graft dysfunction. And so having a modality or trying this contrast ultrasound in grafts, I thought would be a very interesting possibility. And I thought it can help derive early changes and evidences by giving us early cues for graft dysfunction. And so a few words about these microbubble-based contrast agents. See, they are gas-filled bubbles, and these have sort of lowered the detection threshold because they are as big or even smaller than RBCs. And these microbubble contrast agents make use of inert and poorly soluble gases, perfluorinated gases. Their half-life is few minutes. See, unlike this air mixed with saline used by cardiologists, that is only for one pass. It will go off in the lungs with one cycle, but this can last for 3 to 5 minutes. And so you have better opportunity to study how this perfluorinated bubbles gets past the capillaries. And this micro bubbles when injected into peripheral blood, like IV injection, either cubital or thing, and you give a push with saline, followed with saline. This will reach all the organs, not the kidney, but the point of interest, you have the probe on the organ you need and try to see the perfusion. This is actually traditionally used for so many other purposes, but not in transplant allografts. And the commonly used contrast agents are filled with gas by a phospholipid monolayer, and sulfur hexafluoride is the one commonly used contrast, and it's called Sonoview, and it is available in India. And the Logix S-Site machine was the one I used, which has capability of both elastography and contrast ultrasound. So the machine has to have a capability. And this one, and there are now many other microbubbles contrast available now, and different companies promote one. And so this is a typical picture. You see, once you inject and you have the probe on the kidney, you see how you see the bubbles filling the capillaries and reaching the the tissue, the cortex, and very nicely giving you. So this gives a visual picture of how the perfusion of the kidney is there, but this may not be enough unless it is very grossly dysfunction. We'll see some more other pictures. So the time intensity curve. So machines have come with assessing the time intensity curve. You have a your point of interest to put somewhere, and that will give a graphical view of how it gets populated with these bubbles and how it gains over time and deteriorates over time. And you can have multiple points of interest, and you have multiple graphs like this. You can choose the size or area of the point of interest. You can even get the whole perfusion of the kidney like this. And this is with 2-3 areas of points of interest, and they are given in different colors. You see how rapidly they rise and how they come down and how the washout happens. So this is a normal allograft, which was taken actually a few days after transplant, the early transplant. And you'll see that it is perfused immediately, and you see the cortex getting filled as soon as the blood reaches the interlobar and segmental arteries. And this is the graphical picture where the time intensity curve, and I have put it one in the vessel and one in the tissue. The previous reports and all, they pick up from the tissue and calculate the peak and the rate of peak, and also the decibels, the intensity, and they measure it, and they have compared it with various disease states. But here I thought that why not compare it with the capillary as the renal artery, either generally segmental artery I choose, and that is for the comparing base for the tissue perfusion. So you see that this is a normal graph. You see both the graphs more or less lying one over the other, telling us that the perfusion was immediate and uniform and good. And this is a case of rejection. You see that there is you see a gap between the vascular perfusion and the tissue perfusion, and there is some difference in the gradient as well. And this is a severe form of rejection. You see that after some time, the vessel also, you see there is the uptake is very slow, and the tissue perfusion becomes very compromised compared to the vessel. And I don't know, this is not big enough. The machines give you so many parameters like time to peak, the gradient, and the total area under the curve of each of these curves, and many parameters like this. And I think looking at each of this in different disease situations, I think we should be able to give ideas to diagnose these dysfunctions early. And this is a case of TMI. Again, you see, initially the vascular perfusion is intact. There is a sharp rise, but the tissue perfusion was very compromised, and with a severe form. And again, you see that the tissue perfusion has become very less. Only marginal reduction in the main renal vessel perfusion. And this is a case of cadaver transplant with necrosis, ATN. I don't know whether you saw this in the beginning. There was some slowness, even visually appreciable, the filling up. And if you see this, you see here, you see the filling of the capillaries and reaching the tissues, how much time it takes. It was nearly 2-3 pulses of cardiac cycle before it reached the cortex. So I think, and this is a case of CNA toxicity. You see that there is hardly any change in the Doppler, but is there a video here? Okay. Yeah. Again, you will see that there is slowness in the perfusion of the capillaries, and the way it reaches the tissues are very slow because there is vasoconstriction which happens in CNA toxicity. And you see that this is a case of CNA toxicity. Because of the vasoconstriction, I surmise that the capillary uptake is also, the vascular uptake is also having a gradient which is not very upright, and the tissue becomes less and less. And these are pictures of cortical necrosis. This is actually not a renal graft. This is a case of postpartum issue. And you see the B mode hardly gives you any thing, but you see the contrast ultrasound showing the negative areas, and this is more obvious. So this is the area where most of the others were using contrast ultrasound. So with these findings in mind, I tried to do a study, and that was what I presented in the ASDN Congress, and which gave me the prize. And as I prospectively took these cases and tried to see statistically, but let me rush through it, not in detail. It was a prospective study. I included consecutive renal transplant patients presenting with graft dysfunction 1 month after engraftment, and I excluded those with urological and vascular complications, sepsis, and sick patients. And actually, I have record of B mode, ultrasound, Doppler, elastography, and contrast, but I'll have to spend more and more time to see all this. But as a single person but I have the data for all these patients, and I would try to compare the CNI levels. I have tried to compare the creatinine. I'm trying to do so many things, but the study is not fully over it. And the various parameter studies are given here, and not all of them are relevant because these nobody to guide us, because nobody has done this work before, and the different machines have different protocols, and there is no standard. Hello? Yes? Am I taking long? I'll
No, sir. No, sir. Please go ahead,
No,
sir.
sir. Cross-talk, sir. Just
Somebody is a cross-talk, sir. Please excuse us, sir.
Okay. So, these are all pre-given by the machines, but it varies from machine to machine, and there is no precedence and there is no standardization. So, maximal gradient, time to peak, I think if you carefully see all this dysfunction graphs and the etiologies together, we may be able to. This is only the concept I'm trying to give you now. I may not have struck the real targets. And I had 24 patients with graft dysfunction and normal grafts 14 to compare. And the various graft dysfunction causes are given here. And there was a significant difference between normal and graft dysfunction. So that much was obvious, which I showed you in the earlier pictures also. Significant p-values were attained with various parameters like the time to peak, the area under the graph, and the gradient, etc. And what is this? And I try to take the difference between the artery perfusion and the tissue perfusion, and I try to compare between normal and dysfunction graft. Again, some of these parameters had statistically different area. I mean, the difference between these two, the vascular and the tissue perfusion. Then I tried to study the various types of graft dysfunction, but unfortunately, although some patterns I could pick up, the number of cases I had was small, and I could not attain statistical significance. Yeah, so I think that was the essence of my talk. My message is, so I could find the difference between normal and abnormal. I could find some typical patterns, but the number was not enough to give me statistical difference. But also I had a lot of other issues, because this dye costs around 9 to 10,000 rupees. It comes in 5 ml files, and you can't be doing it for one patient. But even earlier studies they have used for kidney 1 to 1.5 ml. So I used to combine a few patients, even AKA I started doing. So I used to take at least 3 patients and charge them just for the contrast, and that is how I collected these cases. And the problem with this collection of cases is, see, the time of diagnosis, clinical diagnosis, time of biopsy diagnosis, the time of this contrast study, all this should be very close enough to give a reliable interpretation. But in my study, I think there were some, I don't think I could do it all at once. And because one case had to wait for the other case, being a single center. So these are the limitations. And I feel that contrast enhanced ultrasound clearly identifies abnormal from normal graft. It is useful in graft dysfunction early, even before other parameters come into focus. And for underlying cause, I think we'll have to do more studies with more numbers. And these are the limitations which I already mentioned. There is limited literature to compare, not much precedence, mission to mission variation, because they are also learning. And if we clinicians don't do and help them, I don't think any of these new modalities will grow. If it is left to radiologists and others to do that, because we'll only know what to expect and when to do this and all that. And I told you the cost of the agent, and this can't be stored for more than 6 hours. That is what is given there. But we, India, we try to store it and do. But I tried once, but I think it deteriorates. Maybe the bubbles get broken. And there was time lag between all these uh, points. Okay. I think, but this ultrasound, this contrast ultrasound is going to come with more and more newer things. And one is this ultrasound localization microscopy, they call it ULM. And I don't know much about it, but this is going to be a path-breaking thing. They say this could give there's something like ultrastructural findings. And these are some of the papers, but there is nothing specific to renal grafts. And even there is only one paper for renal graft, and they have done it some few years ago, and they have not used many of the parameters I have given. Simply, they have found cortical necrosis, they have found cysts and things like that only. They have not tried to study the perfusion characteristics. Now I understand they are trying to use this in critical care, where they are trying to get the perfusion characteristics of tissues, which can forecast the shocks and their prognosis and things like that. So this is going to come in a big way, I think. And we nephrologists, we have the responsibility of giving it a great role in our circumstances. But I think now in these days of early graft dysfunction not being so common, we'll need multicentric studies with more people around. And see, I learned many of this later only. I went through the booklet given by the machine, and because they were not able to tell me. So when I started accumulating the data, I did not know what to look for also. But luckily the data is stored and you can redo it with newer knowledge. But I think I would require more time and do more closer look of all this data I have. And this renal transplant paper came in 2020, but again, they have given, not really gone into the depth of what I've been trying to tell you. I think I'll stop here. Thank you. Oh, I have finished in 30 minutes because
Yes,
I was because with Rajan around, who is very stickler for timings, I was very worried. But I was confident because I was given only 9 minutes to give this talk in fasting. So I started telling, this audience and this forum is not intimidating, but the time limit you have given me is more intimidating. So I have to. That's how
Sir,
I started.
can you unshare, sir, so we can see you when you're talking on this. Since you are leaving, we can finish the discussion right now, sir. And
Okay.
and sir, definitely you have established a path for the progression, sir. And many of us, I think, didn't know that this kind of existence in assessing the renal dysfunction. And thanks to you, sir.
Well, actually, this I've been doing this for past, I think, 3-4 years. But the lack of cases, but with more probing minds like you and other youngsters here, I think you will be able to make more use of this tool. And I could see your enthusiasm right in the morning when you started knowing something about this. I think you are going to come out with more data.
Okay. So one thing, addition thing you have to tell, sir, because if you have a high-end machine, we have to activate by paying 50,000 to the vendor, because this software is different and this activation and cost of the vial is 9,000. So this is what we have to keep in mind. Now I leave it to Shiva sir and Shiva sir for sir, please.
Yeah. I would like to. Am I audible?
Yes, sir. Absolutely, sir.
Yeah, I would like to say 3 points. I remember 3 transplants where we had a nightmare. We had to go for angiography of the graft. One case was renal artery blocked at the site of anastomosis. Second case was acute cortical necrosis in the donor, where we had to angio in the evening of the transplant. And third case was a renal vein thrombosis, where we had initial function and then stopping of the function. So all these cases, I would imagine this contrast enhanced sonography would be tremendously useful, saving us from putting arterial catheters and just a venous injection, and we can know what is happening to the kidney. So I think more and more use of this contrast. Hello?
Yes, yes.
Yes,
Yeah,
sir.
more and more use of this contrast. In Maharashtra, I just inquired 2-3 colleagues of mine where nobody is using this contrast enhanced sonography. Basically, the buzzword and headlines nowadays are genomics and immunology and proteomics and the finer cell-free DNA and so many other things. So imaging is taking backseat. Jeremy Chapman once used to say that biochemistry, microscopy, and imaging are the tools for 20th century. And for 21st century, we will have these 7 branches of new branches of medicine: genomics, proteomics, immunology, and transcriptomics, and all omics technology. So I really wonder, we have to go back to sonography as a stethoscope and use this quite frequently in our day-to-day practice, because it is so simple. Just in sonology, nephrologists are nowadays taking interest in POCUS, bedside sonography, and that will be a wonderful tool if you put one injection and get all the details of the microscopic and microvascular details, what is happening to your patient. That will be wonderful. So we need more and more studies, and Dr. Bala's study is really a pioneer or path-breaking study. I don't know if anybody in India has done this.
Thank you, sir.
Hello?
Thank you,
Yeah.
sir. Right, sir. You rightly pointed out the issues, what is existing right now. Yes, sir.
Yeah, yeah.
This is sure, sir.
Oh, I have all the appreciation for Bala, and I hope he would become the father of contrast enhanced renal ultrasound studies in future for India at least. Huh? God bless him. Thank you.
It must be the first of its kind in India.
True. Thank you.
Thank you.
Yes. Thank you.
Thank you, sir. I think you must leave, as you said, right, sir? No, you have some agenda to fulfill, right?
Yeah.
Thanks, sir. Thank you for all the way you showed the, this real. I got really interested, sir, the moment you gave this topic, and I started exploring. And it's not
one question I want to ask you, Bala.
Yes.
Can I ask you one question?
Yes, yes.
Go ahead, sir.
One of your slides showed fibroscan like thing for kidney, elastography or something you said.
Yes.
Is it for graft or what? It's in for liver. In Aurangabad, we use it for liver.
Yeah.
For
The same question to Bala, sir, this a few days ago. He said for a comparison is doing for everything, sir. Any kind of like in a B mode and contrast and color Doppler, spectral, and along with elastography, right, sir?
Yes, yes. Yeah. See, this elastography, because kidney transplant graft is a superficially placed one, and elastography can be done. But it was not giving me, because the older one I said no, the strain where you give manual pressure. It's sort of, my theory is that CAM toxicity, vasoconstriction, so the kidney will become softer, whereas rejection it will become
harder.
Yeah.
Fibrosis will add to.
Yeah. So
you could find any number for a normal graft? Can it be a follow-up tool for our transplant OPDs?
Yeah. See, this fibroscan, we can't be having that machine with us. So I didn't try fibroscan. Elastography, some of our machines have elastography capability. And the problem with the kidney is a heterogeneous organ where, you have cortex, medulla, pyramids, vessels, sinus. So the softness and the hardness will not be uniform. So that is why my strain elastography, where you were compressing the whole kidney, gave me better results than the newer one, where you can assess it in different places, but it was going chaotic. I had sinus as the reference point, the renal sinus with a fatty tissue, which is inert, which is not affected by any disease. That has the control and the elasticity in the cortex. And I think I will show it my thing.
Yeah, basically why I see its application is because many transplants after 1 year, their creatinine is near normal, but their graft biopsy, if you will find that a lot of IFTA and fibrosis happening around. So that can be picked up by
Yes.
your technique of this, and
See,
it's
FibroScan, that equipment is so costly. I don't think we can have one here. We have regular camps every month and they do, but I have not combined with them for transplant grafts. They do it for liver and, I think that should be there in other centers also. We can't afford to because it costs, I think, more than 1 crore or something, that fellow says.
really.
Thank you, sir. Thank
Yes.
you.
Thank you.
Thank you.
Thank you. Thank you. Thank you.
Ilango, sorry, I think I'll see your presentation in the video later.
Yes, sir. So I think before you go, sir, I just want to say something about your thing. So basically, you've been a torchbearer and creating waves from your younger age, and now this one shows that your brain is still young. And the second thing, sir, like when we are generating so many data points, so the thing is we need to use the technology for analysis, just like what AI does. So basically, you have like lots of data, and you can even do it repeatedly. Like it's not like one time. You can do it again and again, unlike a biopsy. And then you can add some more values. You can even
cost is very high.
Yes, sir. So basically, what they do is they reduce they call it something like dimensionality reduction. They reduce and then they build a model which only uses one or two, and then like what the people use ECG for gating and making ultrasound, echocardiography gating. We can also gate for cortex, medulla. You're gated for blood vessel. And I think it is quite interesting, and I would actually be allowed to work with you, sir. I think you get a good person to analyze. No, like your data is it's gold.
Okay.
Thanks.
Thank you.
Go ahead.
So can you're able to see my slides, sir?
Fine, very clear, but you have to go to play mode.
No, first of all, I should thank Dr. Vel and Dr. Rajan to inviting me and giving this platform to talk. And Dr. Shivakumar makes me feel that I'm still a student. so I've seen him like a student, and I think he's one of the most pleasant teachers you'll ever get to be like as a student. And thanks, Suha sir, to being around moderating this program. So this is the recent transplant we completed 2 months ago, and it's quite challenging and like any transplant. So it's also every transplant you learn something new. So this also made us to learn something, and we want to share what we learned, because in the recent WhatsApp group that there was talk about should we do kidney alone transplant in type 2 primary hyperoxaluria, and I think end of this the answer to that question should be very clear. So even though I'm going to talk on enteric hyperoxaluria, but I think the principles of treatment is virtually the same. So the crystals are very beautiful when we see in the urine, but not so when you see in a graph like this. So this looks beautiful image, but then if you are the transplant nephrologist, I'm sure your heart will break. So here we had this patient doing dialysis for the last 5 years, and there are a lot of information available actually to how to treat patients with hyperoxaluria. So only that I'm actually, this case is one of the cases which tells us that even though the answers are all around us, we always refuse to see. We are unwilling to see. So that's what this case is going to tell us. So before I tell about my case, I'm going to present the case and also what they concluded at the end. So this is a case where the person underwent a bariatric surgery in 2002 and then had a complication with sickle volvulus and had to do some bowel resection and ended up having enteric hyperoxaluria and ending up in end-stage kidney disease on dialysis. So the patient underwent a first kidney transplant 2009, which worked for less than 2 years, and again went back to dialysis. And then they did not relent, and they again did the second transplant, which also lasted only for a very short time. And the third time around, they did a combined intestinal and kidney transplant again this time. And this time the problem happened faster, and then the patient went on to dialysis. So much so the authors were so frustrated, they concluded that in patients with enteric hyperoxaluria, nobody should even attempt to do transplant. So in fact, this was published in American Journal of Nephrology in 2016. And then we could feel the pain the authors had. And so much so they concluded nobody should do. And so this is how they documented, and each time they did, the kidney was okay for the first few months, and then there was a gradual and relentless worsening to failure in all the 3 times. So what we did in our case differently, so this guy is a 54-year-old male, an engineer, very innovative guy, and he is hypertensive with a BMI of 12.5. So you understand people with Crohn's disease, malabsorption, with an ileal resection for Crohn's disease, partial ileal resection with preserved colon. So nothing was done to the colon. And he presented to me almost 5 years ago with renal failure. And he was quickly, we figured out that he had enteric hyperoxaluria, and he became quickly anuric, and we had put him on weekly dialysis, thrice weekly dialysis. For the next 4.5 years, he was doing hemodialysis. So this was the LM picture back in July 2019. And then the polarized microscope showed beautiful crystals. If you are not a patient, I think this, for us, it's beautiful. For him, it's hell. So this was back in 2009. And he also is a treated case of hepatitis B infection on long-term chemoprophylaxis. He stable liver function but however had a compensated chronic liver disease. The last 2 years, he received the denosumab, and after the first injection, developed severe hypocalcemia. The last episode was 6 months ago, and multiple hospital visits for IV high-dose calcium he had to get. His pre-transplant PRA was negative for both class 1 and class 2. So we did a deceased donor kidney transplant with 9 hours cold ischemia time. The donor age was 21, a road traffic accident with no comorbidities. ATG, because of his body mass, he was less than 40 kilos. We had given him, and also malnourished. So already he was immunosuppressed to begin with. So we gave him 25 milligram of ATG, single dose. We never repeated the dose. On 4th day, the CD3 total count was 13 per cubic millimeter. Solomedrol, he received 500 to 250. On 4th day, we put him on dexamethasone. Due to fear that we didn't know how much the oral prednisolone is going to work. And we put him on 1 milligram per kg of tacrolimus and MMF 30 milligram per kg. Luckily, he had a good urine output because, in oxalosis, you want the urine output good. So we were lucky to begin with. So this was nothing because we were anticipating delayed guard function because of long cold ischemia time. And the overnight output also was good, more 12 hours, 4 liters. And we intentionally gave him diuretics. We contemplated on starting the hemodiafiltration intra-op, but when because of logistic reasons, we could not do it intra-op. So we did it as soon as possible, which was roughly around 2.5 to 3 hours after the surgery. And the hemodiafiltration was continued for the next 72 hours. So we have chosen hemodiafiltration because it is slightly better than hemodialysis, even though there are divided opinion on this. I think it's maybe because of the blood flow people have chosen in hemodiafiltration, because you can choose any amount of blood flow. So it depends upon how much you choose. So if the higher blood flow you choose, I'm sure it's going to be higher clearance. So, but there is definitely the case for using hemodiafiltration over hemodialysis whenever we come across similar cases. Our treatment targets were laid very clear. So we wanted to keep the patient alkaline and also the urine pH to keep it beyond 8, because this reduces crystallization. So that was one of the very simple primary target. And the second one we did was, we also monitored the pH. We didn't want to overshoot. And also IV calcium infusion. I was expecting that he may require more because of recent hypocalcemia because of denosumab. But however, it was much more easier to manage with the continuous infusion, and we were only monitoring ionized calcium because in complex situations like this, where you're giving bicarb, you're doing hemodiafiltration, you don't know whether graft is going to work or not. So in these situations, monitoring ionized calcium is the norm, and you're not supposed to look at total calcium. And then we gave him IV magnesium, magnesium being a very potent inhibitor of calcium oxalate stone. And also we gave him phosphorus infusion because we didn't have neutral phosphate, we only had potassium phosphate. We gave him 2 ampules over 24 hours as slow infusion. And in the next post-op day, he was conscious enough to take oral citrate solutions. We gave him 5 ml 3 times daily. And also we continued the oral calcium and we increased the dose. Oral calcium carbonate of 3 grams per day, because calcium carbonate inhibits oxalate absorption. So that's a rationale. So POTFOS, for people who have not used math, often usually comes in 15 ml. Each ml contains 45 millimoles or 93 milligram of elemental phosphorus per ml. And it also has a lot of potassium. So in patients with delayed graft function, this could be a challenge, especially if you're not doing dialysis. So we should be aware of the potassium load. We could not source the sodium hypophosphate, but then because we are doing HTF, so it was not a worry for us. In fact, we had to give him supplemental potassium also because of urine. He was losing a lot of potassium too. So the things were all okay till the first 48 hours. On the third day, he developed altered sensorium, restlessness, hypoxemia. On fourth day, he had to be put on NAV. He was on rice tube feed, but then he pulled out the rice tube. So he did not get any oral immunosuppression in the form of mycophenolate or tacrolimus on the third day. So I didn't know what to do. So basically, like on a Sunday night, I was sitting beside him and I decided not to move out of the room for the next 2 hours because he was going into altered sensorium and we are really trying to figure out what to do. We had a working graft, but then we had a patient with altered sensorium. And so normally we do the TAC level on the 4th or 5th day, but then I decided to check on the same day for some reason. So when we checked, they called me in the night and I sent a random value. It was like he was fasting for more than 24 hours with no medicines being given for the next 24 hours. So it was like after 24 hours, his TAC level was more than 30. And then his platelet count was all dropping and it reached a nadir of around 40,000 with no obvious bleed. So only 2 things was there in my mind. One is sepsis because he's already immunosuppressed, malnourished, also had some compensated CLD. So either sepsis or we're looking at a dose-related TMA. So that's what was running in our mind. And surprisingly, in this case, the pathologist smear, they said no increased schistocytes. And LDH was very high. So normally I give first weightage to platelet count and next weightage to drop in hemoglobin, and everything else like LDH, schistocytes, everything gets a lesser weightage because normally people tend to not know how much weightage to give. So knowing how much weightage to give a single test helps us to navigate when you have conflicting reports. So normally I look at platelet and I look at the drop in hemoglobin, the delta change of hemoglobin. And the next day, when the platelet count dropped further, then I was very sure that the 2 consecutive values with the drop in hemoglobin. So there was a drop in hemoglobin, drop in platelet count. So I decided to put him on plasmapheresis as basically with a clinical diagnosis of dose-related tacrolimus-induced TMA. And the moment we started him on plasmapheresis, his sensorium became controllable. And his baseline pre-transplant platelet count was around 125, 130. And I had initially presumed it probably CLD related, but because retrospectively looking back, the last 2 months later, his platelet count was 2.5 lakh. So retrospectively looking back, it is probably uremic toxin-induced bone marrow suppression rather than CLD. So this is just for people to be aware, because paracresol is a very potent bone marrow suppressant, especially it predominantly suppresses platelet count. So in patients who had protein malabsorption tend to have more gut-derived uremic toxins like paracresol, and it correlates with this case. In fact, we have published recently that we had shown that platelet count is a very strong predictor of paracresol. So we have even built up a prediction equation. We have yet to validate it with paracresol, but we personally have validated platelet count and kidney function with the GFR and creatinine in our hospital. And so it's a very potent uremic toxin. Platelet count is in reduction of platelet count correlates with paracresol. So in this case, the low platelet count was not CLD related, which I presumed initially, and it is related to an uremic toxin. So he improved after the plasmapheresis. Gradually, the platelet count increased, but it was hovering around 80,000 for a long time. But we chose not to do more than 4 because he was absolutely normal, and he even started to walk. He was discharged after 14 days of hospitalization with a serum creatinine of 0.8. And the last follow-up he did 2 months later now, it's 0.75. So this was the dissolution therapy we used when we discharged him. We gradually switched to oral phosphorus supplements. So syrup citralca 5 ml 3 times, with 1.53 gram of citrate. In that, calcium carbonate we reduced. We initially gave him 3 grams 3 times daily. Subsequently, we reduced to 1.5 grams because his 24 hours urine calcium was high. We gave him neutral phosphate, sodium neutral phosphate, 1.93 grams 3 times daily. And we gave him a magnesium citrate, 500 milligram twice daily. I would have loved to give magnesium citrate a higher dose because more than 3 or 4 tablets can cause diarrhea, which can confuse with other problems. So we chose not to give. So initially, the first few days, he got hemodiafiltration. The TAC MMF was the initial immunosuppression along with dexamethasone after the first 3 days. But then we quickly realized and stopped tacrolimus. And a few days, he was only on dexamethasone. When he was on plasmapheresis, he was only 4 milligram per day of dexamethasone. And later on, we added cyclosporin. And subsequently, he's on cyclosporin and mycophenolate. We wanted to make him steroid-free, considering that he is at very high risk of opportunistic infection because of malnutrition, sarcopenia, and net cumulative immunosuppression. And so when we brought down to 2.5, his creatinine inched from 0.57 to 0.79. So I put him back on 5 mg, and we did a biopsy subsequently. We also checked the urine oxalate because we are giving supplements. We want to know, is it really working? So we did this roughly around 1 month after the discharge. And the urine oxalate level was 38. So anything less than 45 is considered a good target. So that means the calcium tablet we are using is working. So when your calcium tablet is working, so that is a definite target. So if somebody is going to treat a patient with enteric hyperoxaluria, so these are some of the cutoffs. So you have to keep your urinary oxalate less than 45. That means you're on the right targets. So his calcium on 3 grams per day, the urinary calcium was very, very high, 642. So we cut down the calcium dose. And the phosphorus, the urinary phosphorus was good. The citrate at 5 milligram 3 times daily was low. 192 was just enough. Some labs would report this as low. The lab where we did, they reported this as the lowest was 115. I would love to keep it around 300. The magnesium was surprisingly good. So I was expecting it to be low because the dose of magnesium citrate I was giving was low. The serum oxalate level was 22.9, the normal being 3 micromole per liter. But still, I think this is actually less than, anything less than 30 is still good for a serum oxalate level. It keeps the situation under control. So even though it looks very, very high, it is definitely high, but still it's manageable. So these are some of the targets. So the urine should be less than 45 milligram per day. The serum has to be less than 30 micromole per liter. And also your other targets has to be reasonable. So these are the targets I had given myself, except for example, these things I have not seen in any books, but there's some things that I've done because I would, in the next few slides, you will know why I've chosen on these electrolytes as dissolution cocktail. So other things we also did was we checked the mycophenolate area under the curve with the help of CNC load. So with 500 milligram twice daily, his AUC was only 12.7. So he's currently getting 2 gram per day, which roughly translates to 50 milligram per kg body weight of mycophenolate. So we do this regularly for our patients, and most of the patients at the end of 1 year will have a beautiful level with 500 BD. And some of them even less, and few of them a little more they require at the end of 1 year. And usually in the first 1 month, 2 months, the requirement for those to keep adequate levels are usually little higher. They generally, for a person who's like 60 kilos, you will require somewhere around 750 BD or 750,000, slightly less than 2 grams. But he probably was not absorbing enough, so he required a very high dose. So it helped us to make clear objective immunosuppression titration based on this. And also the same problem continued with cyclosporin. So initially we gave him 5 milligram per kg body, 3 milligram per kg body weight. And then we have to do 2 levels, and third level we had increased to 400 milligram of neural with diltiazem augmentation, 90 milligram BID. And currently it takes 10 milligram per kg body weight of cyclosporin. So I'm sure this level, we would be reducing this subsequently, but currently in the end, these are all the end of 2 months. So we did a biopsy at 60 days. The primary intention was to see whether I can make him steroid free. So that was the primary intention. And then I saw TFTA1. So this could be an effect of the old TMA, which injury pattern, what we're seeing. But then I've decided not to put him on steroid free after seeing this slide, because you really don't know what is causing this. So this is a full biopsy, adequate sample with 21 glom and 2 arteries, and globally sclerosed 3, TFTA1, and overall intestinal fibrosis, tubular atrophy mild, and some of which is probably related to the TMA he had. And so this is basically not a bad picture for somebody who had a TMA. And then the final diagnosis was mild acute tubular injury and mild intestinal fibrosis, tubular atrophy. So going back to the discussion now, so why we chose what I did. One is we didn't do this role of low oxalate diet. The patient was already taking a very abnormal diet, was taking extremely small amount of nutrition. And then I presume that whatever he's following is good enough for him not to develop oxalate load. So I never tinkered with this. But this is the evidence now. So this is one particular interesting study where they put the patient on low oxalic acid diet, cholestyramine, sodium bicarb, and calcium carbonate, 1.5 grams during the meals. And they did 10 transplants of enteric hyperoxaluria in academic hospital with long-term good graft outcomes. So they followed drip feed and hemodialysis in the post-op period also. And for a while, I think they did it for more than 1 week. That's what in the study they gave, and they stopped when the urine output was adequate, and slowly they started oral low oxalic diet. And so this was quite impressive because they gave calcium, they gave bicarb, they gave cholestyramine, and this is one of the very few trials they've given this, and also diet. So the emphasis was on the diet, and then the longest surviving patient was 32 months with good graft function, with reasonable graft function, 38 ml GFR, and so basically they did only this much, and they achieved reasonable graft function. However, the GFR of 38 and 36, not very impressive, but still decent. So another thing we all should know is this is all from the same trial. So the patient group number 1. So these are the people with preserved colon. So when you have a preserved colon, you have surface area or large surface area for absorption. So you can see here the patient with enteric hyperoxaluria are as the oxalate levels can be as high as people with primary type 1 hyperoxaluria. So the levels they achieve in enteric hyperoxaluria are one of the highest and much more higher than the group 2, which have patients with type 2. And this patient, what you're seeing here in group 1 with enteric hyperoxaluria, this is a patient not on dialysis. So this patient is not on dialysis. These patients are on dialysis. And if you see, the mean is somewhere much higher than type 1. So we are looking at a patient population who have high oxalate load, not and almost slightly higher than even the mean value is higher than a type 2 primary hyperoxaluria. So the enteric hyperoxaluria is not a joke. They are really very painful patients with severe recurrences. Okay, and so whenever the colon is knocked off, that's a group 3 for any reason, the oxalate absorption also again comes down. So it becomes much more easier to manage. So it's only the Crohn's with preserved colon are a big problem. And when the colon is knocked off for any reason, the problem becomes lesser. So you can even predict which patient is going to be painful for you based on the profile of patients you have. So these are the patients they've given us how the diet alone, predominantly the diet, calcium, bicarb, cholestyramine help them to navigate this problem successfully. So they're given 3 patients. And they also commented that transplant in enteric hyperoxaluria is very rare. And at that point in time, when they published in 2017, they had only 16 cases that was published. And they didn't comment on this, but what I saw in this is, this is what I call is connecting the dots. What I saw was whenever the measures taken post-transplant, whenever the word calcium or citrate came, the graft outcome was good. Graft failure, no. The moment it was missing, like you see here, graft failure, yes. The next test, if you see daily hemodialysis, no mention of calcium or any intervention, graft failure. Here they have no intervention, graft failure. And here, no intervention, graft failure. Here, if you see, no intervention, graft failure. And this is the only place where they gave calcium, the graft failed. So whenever they never gave calcium, they never gave calcium or citrate, the graft failed. So it made me think that maybe the oral calcium is so powerful in reducing the oxalate load that people missed it. Even these authors actually missed it in their comments. They never made a mention about how powerful the calcium. Their main focus on low oxalic acid or low oxalate diet. And I think it is a confounder. And their diet also had calcium, cholestyramine, bicarb. And so that's a message I saw in this. So what is the role of high-dose oral calcium? So this is again a different study where they recruited patients based on how the oral calcium intake changed the plasma oxalate levels. So basically, that's what this shows. So the nurse actually gives oral calcium, monitors the plasma oxalate, and also if their urine output was preserved, also was seeing the uric oxalate levels. So when the plasma oxalate levels goes less than 30 micro per milliliter and urine oxalate goes to less than 45, then they plan for a transplant. So that's how they did. And so this one clearly shows the power of oral calcium in patients with enteric hyperoxaluria. So this is basically the same thing what I said here. So next important, in fact, this is to me is much more important than whatever we have discussed so far, because this is the power of phosphorus. Personally, I had a case, a 45-year-old lady. She was my third AB1 compatible patient back in 2015. And she was doing well, and then we figured out that she had type 1 primary hyperoxaluria. But then we went back, looked all the records, and we couldn't have done anything better. She never had a single stone. Nothing was there. We did X-rays. We did even did the CT scan for her abdomen, and nothing came up in that. So the patient was so unlucky. And I maintained a working graft for many months only with oral potassium hypophosphate oral intake. So I used to make her drink the phosphorus Because those days getting AdFos was, the phosphates powders were not very easy. So I maintained whenever she used to have some diarrhea or something, the creatinine used to shoot up, and then it used to be promptly reversed with hydration and phosphorus. So phosphorus is a very potent inhibitor of oxalate crystallization, and I personally have seen in a patient with type 1. So I referred the patient with around 2 creatinine for a subsequent liver transplant. But during the surgery, she died in another hospital. So I personally had managed type 1 for many months with only phosphorus magnesium supplements. And again, this is a publication in 1994 in NEJM. And the first group is basically type 1 hyperoxaluria. The second one is type 2. The third one is non-type 1, type 2. So probably some of them must have been enteric. So this study concentrated mainly on the orthophosphate, oral, and pyridoxine supplement. And if you see, to our all amazement, this way back, 1994, way back, you can see that the kidneys have survived 25 years. We are all looking at type 1 with isolated kidney transplant. We are not looking at liver kidney. And the graft lasted many, many years. So somehow down the line, people have forgotten, I think, the power of phosphorus supplement in type 1 also. And of course, in type 2, you can see here, there's no graft failure for a very long time. So the graft just functioned. So here is 5 cases, here 8 cases, and here like 11 cases. So there's something that we're all missing when it comes to dissolution therapy in type 2. Type 1, I know I'm not going to argue for kidney alone, but I think if any of us is accidentally stuck with a type 1, like you miss it with all, like in my case, there was absolutely nothing that we could have done more than what we did, because absolutely when we went back, we couldn't find anything that we could have done differently. So one of us, we would get into trouble with the type 1, and till you do a liver, you can happily maintain a graft with phosphorus supplement. So this is again a graphical representation of the same, and so you can see an impressive outcome when all the group combined together. Okay, so, and this study also showed one more thing. So even though the title of the paper does not reflect it, they also showed that how powerfully the calcium oxalate supersaturation levels came down whenever phosphorus are added in treatment. So these are all like the hardcore, the basic science work they did. And also calcium oxalate inhibition using some inhibition unit they come up with, they showed, and also the crystallization scores. So phosphorus is a very, very potent crystallization inhibitor when it comes to calcium oxalate crystals. So when coming to citrate, so citrate, I don't know how to rate it, but based on analogous, based on stone prevention data, I think citrate is probably number 1. And many of these patients, including my patient has hypocitraturia, and the mechanism are plenty. And one of the commonest mechanisms is anybody with chronic acidosis, automatically the citrate output comes down. And so this is the number 1 correctable cause all of us would have seen. And this is probably more potent than phosphorus. That's my opinion. Unless you have comparative studies, we really don't know how much this is over and above the phosphorus. And does it have an additive effect? Does it have a synergistic effect? We really don't know all those data. But definitely there is a case for giving citrate supplements also. And so that's why I use magnesium citrate. There's one more reason why I use magnesium citrate also. So magnesium citrate oral bioavailability is somewhere around 20% and higher, whereas magnesium oxide, which is by default, the most commonly available magnesium salt we use, has an amazingly poor oral bioavailability of less than 5%. And so it doesn't stand to reason at all as to why our pharmaceutical company ever market magnesium oxide. The only reason I can think of is the magnesium oxide tablets are smaller compared to magnesium citrate or magnesium glycinate. By default, the over-the-counter prescriptions in US are always magnesium glycinate or magnesium citrate. And if you go and see, if any of you have seen a US over-the-counter prescription bottles, you will never see a magnesium oxide there that often. You will always see magnesium citrate. And then also, I believe that citrate also, when it's present in magnesium, also contributes to reduction. So this is what I call is connecting the dot. Many of us know in 2023, there was I think an NEGM publication which clearly showed a multicentric trial that thiazides are no good in stone prevention. And I've been telling this to many people, whomever I could tell that thiazide has no role, please give potassium citrate and magnesium citrate. Because there is a limit to magnesium citrate tablets, it causes diarrhea. So you're forced to use potassium citrate for the dosage of citrate you need to give the patient. And in some studies, they've given stone recurrence reduction to as high as 95%. So somewhere around 60 to 95% is the stone reduction in normal patients. So this is one more reason why I intentionally gave magnesium in my patient. And we don't know how much this contributes, but again, like there is evidence for reduction of calcium oxalate stone in stone prevention situations. So future prospects there, we have reloxylase capsules. There's an ongoing phase 2 trials also. So I didn't dig too much into this because I feel that we already have the solution. There's no need to give this unless somebody is refusing to take these supplements. So connecting all the dots, summarizing. So this, I made a bubble plot. So according to me, my vote is for the phosphorus, followed by citrate and magnesium. Citrate and calcium, especially for an enteric hyperoxaluria. And magnesium follows that. Low oxalate diet has a limited role. And any form of dialysis also has some role. So the evidence is always there. And I should say that the idea for all this came because during my training, I also happened to see a lot of type 2 hyperoxaluria patients taking a pharmacy preparation which contains usually phosphorus and also magnesium. I've seen them have. So that's how. So I should thank the people of Vellore who made this concoction. But then I've added a few more to it. And so in patients with type 2, so this answer to the multiple WhatsApp posts that was there in the last 1 week. So my vote will be on phosphorus, citrate, B6, because there's a method to even identify whether the patient is likely to be responsive or not based on genetic profiling, and magnesium citrate, and lastly, HTF before, during transplants. So this way, I think we should be able to salvage patients whom we accidentally may be doing type 1 or type 2 hyperoxaluria. Thank you for the opportunity.
Thanks, Ilangovan. Literally, we are overwhelmed by your in-depth analysis in this topic that is not well understood. And we stand before you as a minuscule, and I don't have knowledge to comment. And I invite comments from Siva sir and Siva sir, and we'll finish very fast.
No, I should really congratulate Ilangovan for this. No, I just have one doubt. Why did the patient become unconscious?
So he had a tacrolimus-induced TMA, sir, which was he was having CNS manifestations. He was not unconscious. He was very restless, pulling all the tubes. So
His CT scans were normal.
CT scan, just a plain CT scan was done, sir, and he was not like unconscious. So that was not what. He was very restless. He was quite normal on the next day, first 2 days. He became restless.
And once you have stopped tacrolimus, it has come down.
Yes, sir. Once we stopped tacrolimus, 24 hours later, we didn't know what was happening. So we just waited for 24 hours. When we saw 2 values of our platelet and hemoglobin drop, then we did a plasma and he recovered after that. Plasmapheresis.
No, may not be totally relevant to this, but I do have seen patients in the post-transplant who were not well fed in the earlier days with aggressive dialysis. They go into thiamine deficiency. And when we replace thiamine, they do come back to normal. So this may not be relevant here, but just to keep in mind that these patients, that much more so when they have an intestinal problem, they will be definitely deficient in thiamine. So thiamine is also a good drug to try whenever we are getting confused with their confusion. Thank you.
Thank you, sir. I think I'm actually, I always used to think I abuse thiamine because anybody does not give thiamine to a very confused patient, the person next to me gets scolded always. I always tell them, this is not how you manage. None of you read Washington Manual of Therapeutics. So this guy, we actually gave him overdose of thiamine because like you rightly said, I tend to give him 300.
Okay.
In fact, there is an interesting story about thiamine also I want to share here. We had one case where he had thiamine anaphylaxis. So we had to give him 1,000 milligram of oral thiamine to solve this problem because again, the oral viability of thiamine is only 5% or less. So we solved that problem with the neurologist was confused. And I said, no, this is Wernicke's. And then we had to give him 900 mg tablet 3 times, 3 tablets, and he woke up and spoke normally and he was discharged quickly after that.
Great, great, great. Good. God bless you. Thank you.
So that's sir.
Yeah. You did the hemodiafiltration for oxalates, right?
Yes, sir. Yes, sir.
So his kidney function was fine.
Yes, sir.
And
So
it was all preventive.
Yes, sir.
So that was guided by serum oxalate levels?
No, sir. Actually, what happens is the levels, it comes only after 1 week. We don't get it. So monitoring comes only later. So we did not want to check because we already knew he had very high levels. We didn't want to check it because we cannot guide, our therapy cannot be guided by the levels because the levels come 1 week, 10 days later in our hospital. It's outsourced. We don't get the levels.
No, the timeline of your management, before plasmapheresis, you did hemodiafiltration. Have I understood correctly?
Yes, sir. Yes, sir. First 3 days, he took 72 hours, he got hemodiafiltration. Now, because his graft was good, he was passing more than 8 liters urine, we stopped it.
So you did hemodiafiltration for kidney failure?
No, sir, for oxalate removal. Because his kidney was working. His creatinine after the first 24 hours was 0.8.
So, I mean, suppose I am managing that case, how do I go about prescription of hemodiafiltration when I have no serum oxalate levels?
So we have to presume only, sir, because we have a clear case of enteric hyperoxaluria. The levels are going to be high even in normal people. So we have to...
So it was preventive.
Preventive, sir, because the load, will reduce the load that deposits into the kidney. Because if you don't remove
your
it...
diagnosis of enteric hyperoxaluria was when he was on dialysis, right?
No, sir. It was before he went on to dialysis. He came with a creatinine of 4.5 and 5 years ago.
Since then, you are following him as a hyperoxaluria CKD.
Yes, sir. Yes, sir.
Okay. I didn't get it clearly, so I asked. So I'm sorry.
No issues, sir.
Raj?
It's a really nicely managed case. Plasmapheresis, hemodiafiltration, hemodiafiltration, so many things.
Yes, sir. Thank you.
Raj, can you comment further on this?
I think that I'm spellbound with the
Yeah.
presentation.
Both people have today mesmerized our,
Both new topics. I think we had a very good, actually, new outlook or insight into the transplants.
Thanks, Hilangovan.
Thank you,
And I think that's what you meant by dissolution by particle displacement, right? By concoction of therapy. It's new. It's for us really new. And you just instilled some kind of new idea. We'll follow. And we'll get if any doubt, we'll please clarify, our doubts and all. And as usual, Balasar created a very new vista of a window to the new world. And you created something is existing, but you brought it to our notice. So both of you, I think today is a very useful day for us. Thanks once again. And Sir Suhas sir and Siva sir, thanks for honoring us being here. And thank all the delegates who've been, and also the MCure people who are supporting since many years.
Thank you.
Thank you, sir. Good night.
Thank you all.
Thank you, sir.
Thank you, sir.
Yes, sir. Good night.
Karthi, Thangapandi, bye. Good night.
Thank you, sir. Good.